In the same way as any other difficult thing that you do every single day, you all have this skills and knowledge in your heart. It's just about bringing it up to the front. You've all worked in health for a long time, and so you're very skilled at dealing with people who are telling you stuff that's quite important and private to them. So remember that, and it's just about polishing up that. So it's important to look at the person and respond. When somebody's told me something really private and special to them that's a bit risky, you need to look at them and say, I'm really sorry that that's happened for you. So you're acknowledging that that's something that you're sad about, and that shouldn't happen. It can be quite hard to talk about it. Is it okay if I ask you a few more questions just to see how best to help you? So you're responding to their disclosure, and you're saying you want to ask them more questions, not because you're a nosy person, but because you want to see how best to help them. So it's again that framing, you're giving them the reason why, okay? Sometimes the most important thing I like to know is this something that's happening right now, or is this something that's happened in the past? And that's the phrase I use. I don't say, is it current or historic? That's just trying to be nice and, tight for you. But I say, is this something that's happening at the moment, or is this something that's happened in the past, if they haven't already told me that? Often people will be saying, but of course it's my fault, or, he doesn't mean it, or whatever. So sometimes you need to challenge that and say, actually, nobody should be treated like that. Would he treat, his work colleagues like that? So kind of just reframing it and then saying, okay, now we need to move on. It's really important that it is not our job to fix the problem. It's about recognising that this might be contributing to health concerns and sharing that information, explaining a bit if necessary, and then saying, there are people who are really helpful in this sector. Would you like me to give you some information so you could see who you could get some help from? Is that something you would like? Or, often is the case, once they've talked to you about it, they actually need a wee bit of time to think about it. So it might be something that you say, look, we've done really well today, but how about I see you again next week, or however your workplace works, and we talk a bit more about what might be helpful, because it's rarely a crisis. You've asked routinely. It's not that they've come in a crisis kind of thing. It's really important to recognise that just like smoking, they're not all going to stop or change at that point. It's about uncovering it, recognising it's a health concern and saying, what can we do that might help you to understand a bit more and see what other options there are. And just like smoking, sometimes people won't want to talk about it anymore at that point, but sometimes they would be interested to know a bit more, which they might take up, but they might not. But it's an empowering attitude that you've got to have. You've got to be really careful not to give the message that I'm giving you all this information, and if you don't do it, well, don't come back to me again. And that, we don't think we do that, but actually people are super sensitive. So you have to be aware of that. You don't think you're giving that message, but sometimes people feel that. So just being aware of that. One of the things that if somebody says, yes, it's it's a current problem, you do need to know, well, are they safe at the moment? What's happening? Can they go home? Has talking to me actually precipitated something? What do I need to do here? So you need to ask a few more questions about that, but you also need to have your confidentiality statement in there. So everybody has their own way of doing this, but the way I do it is by saying, look, I need to ask you some more questions, and what we talk about will be confidential between you and I. But if you tell me something that really worries me, and then I'll explain what sort of things might worry me, I'll have to tell someone else. So we'll talk about who that should be. So I'm letting them know I'm not going behind the back. We are going to talk about who it is that we need to talk to next. Does that make sense? So, I mean, that won't work for everybody, and they might not tell you anymore, but that you've got to get it in there. And then you need to explore about what's happening now. Is the behaviour escalating? Are there children involved? What's happening for the children? Do you feel safe to go home today? Is this something you can come back and talk to me about, or do we actually need to get an intervention right now? Is anybody aware of what a safety plan is? Just put your hands up. A few of you are. Okay, that interestingly is something I have very rarely done because I'm not an expert in doing safety plans, but it's an important concept about helping someone identify small things they can do to get themselves safe in a crisis. And it might be small things like having a neighbour that knows what's happening, that you can go to if you need to, having $20 in a plastic bag in the freezer. So if you've got no money, you can get $20 out of the freezer. Just little things like that. And Women's Refuge are absolutely expert at developing these with women and men, if it's men that need it. Okay, so I've struggled because I'm thinking in a general practice consultation, you've usually only got a quarter of an hour. You haven't got time to go through reams and reams of questions about safety. So is there any evidence about short, sharp safety questions, if you like? And I came across this one from Western Victoria, where in Victoria they've done a huge amount of work on family violence in the last few years. And they reckon that if you cover off this information and you have more than 3 positives, that's a really important risk situation. So I haven't done any more with this because I've only recently found it, but I'm aware that you can find lists like this, which it will take quite a while to get through all this. So I want something a little bit shorter that allows me to triage, just like I do when someone comes in with chest pain and I say, how bad is it? Where is it? How have you had it before? Has it been going on for weeks, or is it something that happened last night? I triage all that, and I have my way of doing it. I'm still looking for a nice, neat, quick risk assessment. See, these are all on our health pathways, and they're all really important questions, but that takes quite a while. There are some specific risks to be aware of. Choking and non-fatal strangulation. So I never realised when I started in this work anything about strangulation. And I've been doing it for a couple of years, and one of the police officers I was working for, who was the National Family Violence Coordinator in Wellington, rang me and said, "Oh, Claire, I'm coming down to do some frontline training with the police. Would you help me?" And I said, "Oh, okay. What do you want me to talk about?" He said, "Strangulation." I said, "Oh, I don't know much about strangulation." He said, "It's all right. I'll send you the information." So I thought, oh, okay. Anyway, he sent me this DVD, which had come from the States, where they've now developed a whole strangulation institute, but that's another story. But they had done a huge amount of work looking at the fact that in intimate partner violence, strangulation, or choking as patients often call it, is a really, really common form of intimidation. And so I watched this DVD and then went and taught the police about it. But it made me realise I'd missed it, never asked about it. Thought a woman who had been clearly strangled that I saw in a sexual assault situation, I thought she was a heavy smoker because she had a hoarse voice and a red face, you know. When I saw her a week later, she didn't. I thought, But looking back at it, I thought, I missed that one. Anyway, it's a really important issue. And now when I ask people about it, I'm blown away by the number of people who say, oh, yeah, how often does it happen? Well, often when we have sex, other times when he's angry. I just think, one woman said to me, and she was in her 50s, and she said, oh, but it's okay because I know what to do now. I said, what do you mean? She said, oh, I just put my neck down and make my muscles relax and just sort of collapse, and then he has to let go. And I thought, here's a woman telling me she knows how to get out of strangulation. So, really important because you can be killed very easily. You can also, if your blood supply to your brain is interfered with, it has quite profound effects, some of which are quite subtle and some of which are difficult to find and assign correctly because they're often soft. They're memory, poor memory for the incident. Sometimes people have strokes. A woman I saw last week in hospital had had a heart attack after being strangled. Now, she had never had a heart attack before, but she'd had a stroke before. So nobody's going to say that heart attack occurred because of the strangulation, but it probably did. So really important that we ask about that because it's a very significant red flag in terms of dangerousness. Sexual assault is another thing that we need to know about because that often escalates, and it's a big red flag in terms of this is not going well, this relationship. And then you need to be aware about mental health concerns and things like the risk of suicide for the patient and for the perpetrator, who will often threaten to kill himself if she ever leaves him. So you need to know about those things because they're quite high-risk situations. And then what about the children? What's happening with the children? Are they at school? What are their behaviours like? Have they ever been involved in the violence? Does Orang Tamariki need to be involved at this point, or is that something that we need to do subsequently? So in general practice, I have found, in my experience, I've rarely had a crisis. That's really important. I'm routinely inquiring. It's not like people are coming in being strangled. I see them separately in another role, but So most of the interventions I'm finding that I'm doing are kind of lower level ones when people are saying yes. And I'm needing to give them some information. I'm giving them some pamphlets or a link to a really good website we've got down in Christchurch. I'm doing a brief intervention. I'm letting them know that there are other things that can be done, and it would be really helpful for them to know about those, and these people can tell you about them. I'm not saying you've got to leave or anything like that. I'm just saying there's other ways that people can manage this. If I've got higher levels of concern, then I might be involving the police or handing over to a resource person in my practice who's got more time. Well, I'm carrying on with my list of patients, and I'll illustrate how I did that in another case. Sometimes you need to ring the police together. I'll ring them and you talk to them, that kind of thing, or refuge or whatever. And always offering this ongoing support and follow-up. Look, you've told me some really important stuff today, and it's hard to take it all in for you, what I'm saying to you. So how about, now we've discussed this, I see you again in a few days and we see what you're thinking about and what your thoughts are and what you'd like to do next. Because often people can't decide when it's all just come out. It's very traumatising. So in summary, responding to disclosures of abuse, this is kind of your brief intervention type thing. You reassure them it's okay to talk about this. It's a very brave thing that you've done. And if I can ask you a few more questions, it would be really helpful to see how best we can help. If they are saying, oh, but it's my fault and that kind of thing, you just remind them that actually that behaviour is not okay. And it wouldn't be got away with in a workplace or in any other circumstance. Assessing their immediate safety is important. In the same way, if somebody comes in with chest pain, you triage them. It's not a new concept, it's about triage, really. And then you offer referral options and follow-up, and then you document. Because if you don't, how does anybody know what's going on? And how do you know what you said to that person last time? Really important for the woman, because it may be that she never decides to do anything at the moment, but in 3 years' time she does. Do you remember when I talked to you about that stuff that was going on? Well, I've decided to do something about it and the police would like your notes. If you haven't written much, it's very poor support for her, really. Okay, a few case examples. So this woman was one of the women who presented when I was doing that audit. So she was a 23-year-old young woman whom I hadn't met before, and she came in for a postnatal. So she had a 6-week-old baby with her, and she had a toddler who was wrecking the room. She had a big bruise on her cheek, and I said, look, how's it all going? And she said, the baby's not settled, it's been really hard, and the toddler's been really demanding. I thought, yeah, I can see. Anyway, I said, have you got any support at home? She said, well, my partner's back. He's been away, and he's not coping well. He's very irritable and short-tempered. So then I said, is that how that happened? Yes, it was. So we talked about that. So I was really concerned about her. Her partner had been away in jail. And he'd come back and he wasn't coping with this and he wasn't coping with being out and she wasn't managing at all. She got a 6-week-old baby and the toddler was at risk of getting a good belt round the head from the partner too. So I thought this is the acute crisis situation. I still had a room full of patients. So I said, look, I think it's really important we do something to help you, and I know just the organisation that can do that. And what I'd like to do is pop you next door and I'll ring Refuge for you, you on the phone, and then I'll see my next patient and I'll come back and see what's happening. So that's what we did. And Refuge got her out of Christchurch, somewhere else where she had a safe family, extended family, to support her. So they did all that. I didn't have to do that. I had to facilitate the next bit, but I didn't have to. They came to the surgery and they took her away. So it was really, really good. And good for me, good for her. I couldn't give her a pamphlet and say, go away. But I didn't know how to get her anywhere safe, but they did. They were the experts. So it worked very well, and that was the one that took half an hour, not 10 minutes.
So in order for that process to be well supported through maybe sensitive claims and ACC, do you go down that track right then and there, or do you just wait?
Well, no, she hadn't actually disclosed a sexual assault at this point.
Oh, okay.
This was a physical assault.
Okay.
So she had a bruise on her eye, but I was doing a postnatal, which was funded anyway, so that was okay.
Okay.
Now, we talked a little bit about safety planning, but this is just a brief sort of overview about what safety planning might look like. So supposing it was a different situation and the woman actually wasn't at high risk like that, but wasn't quite, she just felt, things are ramping up a bit and she needs to have a plan to get out safely. This is the kind of thing that will be done by Women's Refuge, and they'll be talking to her about becoming safe. They're coming this afternoon, so I won't take over their talk, but that's what safety plans are about.
Claire, did you think about would consent at that point? Would you consider that?
Yes, absolutely. Yeah. But in the event, what happened was she went into refuge and they let me know that they'd taken her away out. Yeah. But certainly. And if she had said, no, I don't want to talk to refuge, that's what I would have done.
Yeah.
Because I was not, she was in no way could she protect herself or her kids. So. Okay, so much more commonly you'll have situations like this. So Jeremy was at the Polytech in Christchurch, and he wasn't my patient, but I had a quick look and I saw that he often came in with sort of minor things, like coughs and colds and a bit of a rash and whatever, which is unusual for a kid at this age. And so this time he came in and he said he wanted an STI check. And so I asked him about his relationships, and he disclosed about a 3-month abusive relationship with a male. And he was really embarrassed and had never disclosed to anybody about his sexual orientation. And it was very controlling and older. Was in his late 20s he was, the other person. And starting to be isolating. And his partner had been going with other people as well. And that's why he thought he'd come in for the STI check. But he wasn't in any headspace to think about leaving or going somewhere particular. But we did find that the place he felt comfortable going was actually to the Polytech counsellor. And with his permission, I rang the counsellor and said, what he'd told me about, and that he'd like to come and talk about what options he had and get some support. And so he wasn't a person who would go to relationship services or, a men's shed or something like that. It was way too confronting. He just needed a gentle nudge into someone who could then talk about relationships with him. And he was happy with that, and he took that up. So I didn't have to do any more than that. And they took over the other ongoing support. So supposing he'd said no, he just, I could tell him about the relationship, but he didn't want me to refer him on or anything like that. It's okay. That's okay. It's just like smoking. Depending on where somebody is in the process of change, they won't actually necessarily be ready to hear all that. And don't waste your energy the same way we don't with smoking cessation. If somebody isn't at the point to start making changes, you kind of put your energies at a different level. So understanding that wheel of change and using it in this context is very helpful. So deciding where somebody is in that process of change and kind of targeting your intervention at that level is very, very helpful and familiar to all of us, so that it makes it much more achievable, if you like. What about recording? I said you have to document things. Now, in our general practice, we use MedTech, and what we've done is we worked with our PHO and we made family violence, FV, a screening option. And so when I do the screening, I put up family violence, and then I choose whether or not there was a concern. And then, for example, here, disclosed past concern, and we discussed it, but she didn't need any further onward referral. It might be up here that she's got current disclosure, we discussed it, I'm quite concerned, she's very hesitant, denies issue, so revisit it in the future. So I've put a reminder to myself, in 3 months I've got to remember to do this. So it varies as to what your patient management system is, as to how you do it, but it's a really good idea to have a practice or group-based decision about how you're going to do this.
Would you put it in prompts or diagnosis, or,
Would you?
Would you?
Would you? Does anybody?
I have actually.
Do you put it in classifications is probably the way we would be thinking. Yeah. Do you put it in classifications? Yeah. I'm just interested to know what you all think.
I think it'd be dangerous to do so, because if you did a discharge summary and you sent it out to her, I mean, it could put her at more risk.
I just asked them, and I said, look, is this okay if I put it? I can be sure.
I guess it depends on the context in where that information might be going to next. So I don't at that time, because this is a practice-held thing. But it is something to think about who else might access that information and in what circumstances, because once it's gone from your environment, you don't know. The person who reads it might be quite an appropriate person, but they don't know who else knows. Oh, did you know that so-and-so got a bit of a problem there? You know, they might be saying things completely innocently, but it's all shared. So you have to be careful, really do.
The perpetrator might control their Manage My Health or patient portal or something like
Well,
that.
that's right, that's right.
I had a discussion about this yesterday when I was doing a talk for some GP students, and they were saying around remembering the privatisation bits on the portal, so keeping this stuff out of the general portal, that if it's a 15-year-old girl, for example, their parents may still have access to the portal, or the partner, so just being really mindful of what you put in.
So it has to be a practice discussion as to how you do it, and that everybody knows what everybody else is doing, otherwise it's too itsy-bitsy. Now, because of all of this stuff I'm telling you, for some of you it's all familiar information, but for others it's not. So I mentioned health pathways before. Is everybody familiar with health pathways? Anybody not? Put your hand up. Okay, so a few people. So health pathways is a computer-based information source used in primary care and in some hospitals now as well. And what it does is it's got lots of pathways, 800 or 1,000 pathways now, and you can look up things like urinary tract infections, and it gives you assessment and management and referral options in each area of New Zealand that has health pathways. So on health pathways there is a family violence pathway, physical assault pathway, sexual assault pathways, which in many places have been localised to make sure that the local referral options are available. If you don't have health pathways, or your region doesn't subscribe to health pathways, which as I said is around the Hamilton area, you can access this standalone website which the dear IT people put up for me as an independent website, which has just got the family violence, physical assault and sexual assault on it. It hasn't got the rest of health pathways. So you have to put in that URL. You can't Google it, it won't get you in. And then once you've got in, you put in the username of assault, and the password is assault with 5s and a 1 at the end. And when you get in, you'll get the same view as I'll show you in just a minute, like this. So the view you get on the freestanding one is the Canterbury pathways, because I'm in Canterbury and it's the Canterbury ones they've let me share. And it's only this bit. That's the only bit you get on the freestanding one. But as you can see, the rest of health pathways covers all sorts of areas. So for those of you who are familiar with health pathways, you just go in the normal way. You can put your search term in up here and put assault or family violence, or you can find it because you know it's under medical and it's the first thing on the list because it begins with A, and that's why I called it this, because I knew it would be at the top. And then you choose family violence, so you click on the blue button. And I've put you know the drill because those of us who are familiar with it recognise that you always have assessment and management and referral. All the pathways are framed in the same way, and they're all framed with having the blue writing means there's more information if you click on that link. So when you look at assessment, it's quite short, it's not overwhelming, but when you click on these boxes, it reminds you of the questions and things of importance. So you can click on them to help yourself remember. And then in management, it's divided into if there is a disclosure or if there isn't a disclosure. So it kind of helps you, and it doesn't overwhelm you with information. You can select the situation that's working for you. And for example here, if you're in a crisis, what are the contact numbers in your area? Again, it will work if your pathways have been localised, which they haven't everywhere in the country, but it gives you the contact details there. And then community support agency, so a whole range of options here. So for example, in Christchurch we've got 5 different sorts of refuge service. I've also added to the bottom of the elder abuse one that EARS phone number that I mentioned for the 78-year-old woman. EARS is elder abuse referral service, is it? Or listening service? I thought it was listening service. But anyway, it's a phone number which goes through to age-concerned nurses who are very skilled at talking about elder abuse, and it's a very good support for people, older patients, and their families too. And then there's also the stopping violence services, and I couldn't fit it all on the screen, but there's also services for males too. And again, you can click on other links if you need to go to a different page.